All right. Well, thank you everybody for taking the time today on your Saturday to spend that with us here. I've got a lot of exciting things I want to talk to you guys about in regards to some strategies for self-monitoring blood pressure programs at home, providing them remotely. So my company is Tupelo Life Digital Therapeutics. My name is Rob Sanchez. I'm Chief Operating Officer here for Tupelo Life. And the goal today is going to be to present these three strategies and compare some of the pros and cons associated with each one and show you what worked. But first, a little background on myself. I've been an RN for over 21 years now. For the last 10 years or so, I've spent in the remote patient monitoring space and telehealth space, working for IT companies that develop technology for patient management at home. So programs like what I'm going to talk to you about today, I've been spending time with that. So I take the clinical considerations along with the business considerations so that we can make a good program that's going to be fundamentally sound from a clinical perspective and then make sense for your business model perspective as well. Tupelo Life has been working with the American Heart Association for a long period of time now, doing a lot of IT services for them. And then most recently, in the last 5 years, we've been part of the Center for Health Technology and Innovation. So we're an innovator member within that segment of the organization. So we're very excited to continue our work with the AHA. So let's jump into the first strategy. The first strategy is really taken from the check change control program that we were part of with the AHA. We looked at this program and just a little background on it. The premise of this program was to help patients, provide them with a tool at home that they have access to steadily journalize their blood pressure readings at home remotely. So the premise is you bring your own device, you take your reading and you enter it into a program. And then that program would connect you with a volunteer, either a health coach or a provider that would engage with that person on a frequent basis to educate them, to give them content, and to provide some knowledge on hypertension control. This program ran for about 4 years. And what we saw in this program, after we dissected all the data, the average age was about 57 years old. The average blood pressure start for this program was 129/80. And the systolic blood pressure reading ended at about 126/79. A couple of keynotes that I want you guys to know about in this program. The participants were asked to take their blood pressure at least twice a month for a period of 4 months. So that's 8 total readings within that time frame. Some patients did a lot longer, some a lot less, but in average, this is what we saw, about a 3-point systolic drop. Now, some of the key considerations that we found here is that as providers, we saw that we relied heavily on self-reporting. Did the people have the self-discipline to do this more than what we anticipated, more than what we asked? We put a lower threshold, and the answers were all across the board. And the third consideration was the accuracy, not only in the accuracy of the device that they were utilizing, but accuracy in, were they putting it in correctly? Were they taking the device, the reading appropriately? Were they sitting down? Were they resting? Things of that nature. And I'll talk a little bit more about that in the next coming 2 models. So those were all things that we felt like we needed to improve upon. And one of the ways to easily improve upon was to make it easier, not only for the patients, but also for the providers, because we did start seeing some benefits for a remote monitoring program like this. So the next iteration was, we dubbed it a high-tech, low-touch. So the first one was low-tech and low-touch. This one is high-tech, low-touch, just in the sense that in this program, the company that started an RPM program, which was Health First Telemonitoring, which is a company that Tupelo Life later bought out, was providing the high-tech, meaning connected cellular-based blood pressure devices to the patients. Low touch, meaning there wasn't that clinical outreach on a day in, day out basis. The focus was mainly on addressing those hypertensive crises alerts, right? If anybody was over the 180/90 threshold, they were getting a phone call from their practitioner. These practitioners were getting so the premise of this program was we created a special software for it. The devices were connected to this software, and the data was automatically going into that software. So as a clinician, as a practice, they had access to their population in one platform, and they were able to see who was at high risk and at what levels. So from there, these patients were able to get reminders on a daily basis. So we did see a lot more touch points from that perspective. But the focus was on the alerts, only on those elevated critical alerts. So what we saw is an actual increase in the systolic rate, starting at 141 over 78, the average, but it went up to 146 over 81. 5-point increase. Why? Right. I'm going to talk about that. That was a big reason for our shift in our third iteration. But one of the things that we felt was critical was that these patients, the knowledge deficit was not being addressed frequently. So we were not being able to really take into consideration those people at the rising risk level, right? What we call rising risk, that were in stage 2 hypertension, over 140 over 80, going all the way up to the 180 over 90 mark. What happened to those folks in that category? We felt like we needed to address those a little better. So the last iteration that we developed was the high-tech, high-touch. This is where we're at now as Tupelo Life Digital Therapeutics. Here now we've created a program that's structured, that has the connected devices, that has a program that people can actually understand and follow and get guidance from a RN-led clinical team. Those were very important considerations for a program like this to have. And what we saw is that the average blood pressure, and this is ongoing data, by the way, the average blood pressure start was 146 over 82. And by the end of a 13-week period, it's dropped to within the HEDIS metric of 138 over 77. Very incredible drop. And for us, what we felt was a big impact of it was the ongoing education and understanding of where these patients were at and meeting them where they're at, right? So as a result, we saw 0 hospitalizations during that time period for these patients. We saw an increase in both patient and provider satisfaction, and our clinical team worked with them to help them understand the importance of medication adherence, doing strategies that for a lot of the clinicians on the line are, kind of self-explanatory, but for a lot of folks, it just doesn't happen as we would like it to be. So for instance, taking their medications daily, trying to take them at the same time every time, and then really scheduling refills appropriately were key factors. And we saw a 70% improvement from those in medication adherence. So what were some of the considerations that led to the success of this third iteration? So we feel like it's really important that patients feel empowered and witness their blood pressure numbers. So making them understand and learn their BP number is critical. Having them have access to their number was also critical. So we developed an omni-channel approach that we're calling. And I want you guys to realize that this is really important, that for them to have access through their smartphone, through their tablet, through their computer at home. And then for those that, we took it a step further and we created a booklet that was comprised of educational content from the American Heart Association. We integrated our care plans into it. We integrated some of the care plans from them as well, and created the 13-week journal. Here, this journal was given to these patients. They were able to write on it. They were able to document notes that they would take from the conversations that they had with our clinicians. And they were able to see some of that success ongoing. So seeing that number, understanding that number, and seeing it drop was critical. As an example of a use case, we had a patient that recently did a video for us that was so happy because he had foster kids that he was doing this for, had blood pressure very up and down. He started the program at 157 over 76. Through our 13-week period, he dropped it downward of 20 127 over 66, and he feels fantastic. So, examples like that we had a lot of, and we're able to get the patients engaged, which was absolutely critical. I do want you guys to know that this is labor intensive. So a lot of times, a lot of the feedback, a lot of the apprehension that I get, particularly from providers up front, is I don't want a lot of this data. Well, it's important for them to realize that you want to have an RN-led clinical team take lead on this, right? Because many times a lot of these providers want to utilize maybe non-licensed personnel to manage this program. And what winds up happening is folks like that aren't equipped. They don't have the practice, the industry experience to manage and triage these patients proactively. So they'll do the best that they can, but meantime, they're going to pass the football back to that provider. So they're kind of back to square one. Instead of really having the provider someone that can triage everything and only let him or her know about what they need to do for that patient and take initiative with that or take action on that, because that's really what they want. It's like, what do you want me to do? Without having an RN-led team that's going to have the confidence to manage the patients and then just give the data or the information to the doctor on those patients specific, that's going to make this a lean, mean machine that will lead to positive outcomes. So those are two big factors, lessons learned that we continue to evolve on. And then the third one is that collaboration with the provider. So a program like ours, we are an extension of the practice of the providers, whether it be a post-hospital discharge group or a case management group at a family practice. We feel like we're an extension of them. So we want to make sure that the collaboration from their perspective and what they kind of the message that they give to their patients is also at the same level. So when the patients get feedback from the physician or that about our program, then the patients are going to be more respondent to the advice and the care that our nurses are going to be doing. So those are some key strategies for a high-tech, high-touch program. Really quick, I want to give a shout out to Dr. Austin Ogwu, doctor at Alpha Medical Center we work with. This is one of the several clinics in the Dallas Metroplex area where we're located that helped us out. His staff was really gracious in working with us and his patients, and it was an honor to work with them. So I want to thank him for his participation here. But I want to leave you guys with kind of how can we leverage RPM for self-management of blood pressure moving forward? Many of you know that there are more CPT codes coming up ahead next year for remote patient monitoring and remote monitoring therapy coming out, or RTM. So this is a growing area. So I think what we saw is there's 4 areas. Number one, avert health crisis, of course. Addressing those that are 200 plus that are in the critical state over 180 over 90, for instance. We want to be able to address this. We're going to have an impact in hospitalizations, unnecessary hospitalizations at that point. Number two, we also want to slow the disease process. So going back, look at that second model, for instance, where we didn't really impact that category of 140 to 180. We want to be able to coach those, educate those folks, and try to bring them to within HEDIS, which is our third goal of targeted health metrics. By doing that, we'll be able to bring folks within that 140 threshold that will allow for some incentive goals to kick in. And then the fourth component is patient and family satisfaction. Also a key metric nowadays for.
Thank you, Rob.
Are we out of time?
Our time is up, but we do have a couple questions in the chat. If you might be able to answer those, folks, that would be wonderful. Thank you for your presentation today.
Wonderful. Thank you.
Thank you.